Welcome everybody to day 2 of our Seniors Forum. We're so excited to have you all with us here today. We're extraordinarily honored and blessed to have an incredible group of speakers who are generously giving their time to spend with us and share their wealth of wisdom. The 2021 Virtual Seniors Forum is presented by Age Friendly Edmonton. We could not do it without them. We're really excited to have Chris with us here today. A little bit about our speaker and our session that we're going to be leading off with is, let me just make sure that I can read 2 things at once. I'm sorry. Here we go. All right, so Chris, who's with us today for 5 quick quips on quality health information. Chris is a board certified geriatric pharmacist. He's a certified diabetes educator and a S.T.O.P Quit Smoking Certified teacher. He's a board member for ESCC, the Edmonton Seniors Coordinating Council. He graduated from the University of Alberta, the Faculty of Pharmacy in 2021, and he's had the pleasure of working in multiple practice environments, including both independent and chain retail stores, long-term care, AHS, policy development for community living, and Pharmacy Student Preceptor for the UofA, the 4th year and doctorate pharmacy students. We're so privileged to have you with us here today, Chris. Thank you so much for sharing your wisdom with us now. I'll give you the floor.
Perfect. Thank you very much. And just a slight correction, and probably I typed it wrong, but I did graduate in 2001, not 2021.
Oh, so thank you.
Good old 20 years of experience. Pretty good. So what I'll do is I'll start the screen sharing now, and we'll start the presentation. Okay, so like she mentioned, we've got the title of the presentation is 5 quick quips on quality health information. We will possibly, if we have time, get into a 6th one on blood pressure monitoring. So the idea of this presentation is we're using evidence to make an informed decision. Everything anyone does to their own body has to be their own decision and should be based on hopefully evidence and an informed risk. So you're making the decision for yourself. Any healthcare provider, such as myself or a physician, should solely be giving you information to allow you to make that decision yourself. Nothing we do should be forcing you into it. So the first thing we'll go through here, I'll spend about 5 minutes going through numbers and how to understand numbers that studies or a conversation with a doctor can bring up. There's 3 primary ones that we'll look at, including risk. And if you understand those numbers and how they're generated, it gives you a better idea of what your own risk is and how you can apply it to you. Again, we'll talk about application of that information to yourself and whether any study is even applicable to you or applies to the treatment group that you're looking at. We'll go through the studies that were described. And then further to that, I'll give you a little bit of information on where to gather good studies. A lot of it, unfortunately, is hard to find and reading studies, but hopefully there's some sites in BC where they do a bunch of data analytics or reviewing studies, as well as Alberta. There's something called Towards Optimized Practice. So the first one is, do you know the real story? And there's so much misinformation out there, as we can tell through COVID, through studies that are released, through marketing for products. And so when was the last time that you heard for marketing on a product that this is better or is effective? And what does that mean? So effective could mean it benefits 1 in 10,000 people. According to a term, that's still effective. So we want to look more at the background information and what does that mean? So the question you should always ask is, should I be taking this? Every medication, every review that. Many people seem to think that once they start on something, it has the same effectiveness throughout their life or the same risk throughout their life, and that is definitely not the case. So knowing the facts does allow you to decide for yourself. So first of all, we'll start with looking at evidence and what to look at in that evidence. So the first thing to consider always is the study group. Does it apply to you? So things like age, sex, other diseases, race, all play a role. So a study done in a South American population of teenage men likely would not apply to a seniors population in North America. And the same goes for men and women when it comes to certain types of medication, hormone changes, things like that. Obviously, studies are done in those different sexes will show different results. And one of the studies that we'll talk about later in diabetes will reference that, where they couldn't even separate out the data for males and females. So it didn't, the information that you get from it doesn't apply very well. Second thing is study design. So best level of evidence is a randomized controlled trial. And what that means is the two groups are assigned to no treatment or a placebo and a medication, and then followed up for a period of time. And the longer a time frame, the better, because you're better able to get results. The lowest level is just from a clinical review or a follow-up review. And the majority of studies that we'll discuss today in sleep and diabetes and in a lot of seniors trials are follow-up studies. So all they're doing is reviewing people who happen to be on a treatment over a course of time and seeing what happens. Unfortunately, not the best for evidence. So then the outcome of the study. So if people are looking to prevent death, is the study looking for mortality? Or is the study then saying, well, people had a reduction in stroke or hospitalization or kidney failure? So does that information match what you're looking for? If it doesn't, or the study isn't designed to look at that, unfortunately, the information can't be used very well. And the last and most important part for all of this is, what is your risk or your baseline risk? So when we talk about baseline risk, is what is the risk of having an outcome over the course of time without any treatment, just in the current state? So if that risk is high, and we try not to use terms high and low because there are ways to put a number on it, but if it is high, you would expect to get more benefit from treatment. If the risk is low, and I'll use the example of, well, we'll talk about it in influenza. If the risk of catching the flu is 10%, some people will choose treatment. If the risk of catching the flu is 1%, people may choose otherwise. Now, it's definitely higher than that, but we'll talk about that. So now we'll get quickly into the math. And so what I'm going to use is always, I'll use the example of a group of 100 people because it allows us to get a percentage. So most often you'll see information that's presented and saying it reduces risk by a certain percent. So when we get into statin therapy for high cholesterol, one of the historic things with Lipitor, which is one of the drugs, was that it reduces the risk of a stroke or a heart attack by 50%. Now that may be true, but we have to put that into numbers. So out of a group of 100 people, if you had 40 people that would have an event on no treatment, so 40 people just naturally over time would have a heart attack or a stroke, and 30 people would still have it on while they were receiving treatment, there's a reduction in 10 people over the course of time. But that is a 25% risk reduction because only 40 people originally had it. Now the same case goes if you had 4 people out of the 100 that had no treatment that had the event, and 3 people that had treatment that had the event. That's still a 25% reduction. So big difference in the actual number of people that benefited, same percentage reduction. So the number that should be reported in most studies is something called absolute risk reduction. And that means the absolute number of people that benefit as a percentage. So in that first group, when we had the reduction of 10 people out of 100, it's a 10% absolute risk reduction. For the second group, where we only had 1 person benefit out of 100, it's an absolute risk reduction of 1. So only 1 person out of 100 benefited. Goes into the number needed to treat, which is an easier form of looking at it, which is just the 1 over the absolute risk reduction. So in the first group, you would need to treat 10 people to benefit 1 with therapy. In the second group, you would need to treat 100 people with treatment over time to benefit 1. And so you'll usually see good statistics reported as either absolute risk reduction or number needed to treat. The last statistic we'll talk about is number needed to harm. So what you may see in some studies, and this is typically used when the harm of the treatment is actually greater than the benefit, is a number needed to harm. So a number needed to harm of 10 means 1 out of every 10 people is actually going to receive harm. And you can have a number needed to treat of 10 and a number needed to harm of 10, and then it's equal harm and risk. Okay. If people do have questions about how to understand this, I will provide the slides to Age Friendly Edmonton and Amber so she can post them, but also you can ask questions at the end. So first of all, we'll talk about an aspirin a day. And hopefully people have heard information on this in the past few years, because there was a study completed in Canada and actually partly done in Alberta, following up people with no underlying cardiovascular disease and determining whether aspirin would be a benefit. So the question that we ask is aspirin effective for reducing cardiovascular events in patients without pre-existing cardiovascular disease? So this does not apply to people who have already had a stroke, a heart attack, a revascularization, so meaning heart surgery, but it does apply to those people who do not yet have that. So 3 main studies, all randomized controlled trials, so all quite good evidence, all in 10 to 20,000 people. So again, quite good studies. First one done in patients with what they define as moderate cardiovascular risk. So a 10 to 20% risk over 10 years of having a stroke. Primarily done in people, I believe it was 60-year-olds, was the average age 63. And there was no difference in cardiovascular events at all. And it increased GI bleeding by a very small amount. So when we talked about number needing to harm, an additional 1 out of every 345 people treated would have a GI bleed compared to any benefit. Second study, again, we'll talk about different groups that it was done in. So it was done in diabetics with a 7.5-year follow-up, which is a decent length of time. The cardiovascular events in the treatment group were 8.5%. Placebo were 9.6%. So it reduced it by approximately 1% total. So you need to treat 90 people to benefit 1. And it did have an increased risk of bleeding by about 1% as well in total. And the last group, which applies to this population that we're talking to today, was 19,000, what they defined as elderly patients. So average age of 74, but it ranged from 65 and up, showed no difference in cardiovascular events. So a slight reduction, but not statistically significant. Did increase fatal or major bleeds by 1%, and it actually increased mortality, which means death, by about 0.7%. So it actually caused harm in about 1 in 100 people. So the conclusion for that: routine use of aspirin for primary prevention should be discouraged. Potential benefit of approximately 1% is offset by the similar increase in bleeding. And so Tools for Practice is one of the references that I was going to talk about. It's both funded in BC and Alberta, and all they do is review studies. So it is a very good reference, and they list it here. Now, one criteria I will make to this is if you are currently taking aspirin, the recommendation is also not to stop without discussion from your physician, because some people do have underlying platelet disorders. And there was a study done in Alberta and in Canada that showed that approximately 3% of people over the age of 65 have a slight atypical heart rhythm that hasn't or is undetected or typically undetected, and aspirin may benefit that group of people. So the second one, and the most fun one and most recent one out of all of these, is statin use. So statins are a class of drugs that treat high cholesterol and have been marketed and have evidence for prevention of further heart attacks or strokes, especially in people who have had them, but are being used to prevent them as well. So best evidence for statin use does come from 28 randomized controlled trials, and they unfortunately enrolled mostly men, men being higher risk, men also unfortunately historically being the most studied group due to healthier at younger age. So they were primarily study groups. And in BC, which is where most of the data comes out of currently, is about 47% of men, 33% of women took a statin who were over the age of 70, and 50% of those people were for primary prevention. And that means they had never had a heart attack or stroke or known coronary artery disease. So it's just risk and potential benefit of it that was expected. So in 2019, a number of studies did come out shortly before COVID, and the updated information was in people with proven vascular disease, they do improve survival. So statins do improve survival. Over the course of 5 years, they reduce the risk by approximately 12%, somewhere in there. But a number needed to treat of 1 out of every 77 people will benefit. The risk of serious adverse events, which is slightly different. They had strokes or coronary events listed into there, and it was 0.77%. So it equates to a benefit of 4.5%, or a number needed to treat of 23. And while people may think a number needed to treat of 1 in 23 benefits is very small, that is typically the average for most cardiovascular medications, somewhere between 10 and 20. Now, when we look at primary prevention, so people who have had no prior event over 5 years, so they studied these people for 5 years on treatment, there was the reduction of serious adverse events, which included death, revascularization, heart attacks. There was a reduction, but total serious events, which included any other minor medical event, disability, permanent damage that was recoverable, did not change. So the primary outcome for that one was death, and that didn't change when you looked at a combined outcome of total serious events. So it does benefit a small group of those people. And in 2019, cholesterol treatment trialists collaboration, so you can see the name there at the bottom, followed up 186,000 people. But of those people, only 15% of people were over the age of 70. So not a large group of people fell into the senior or elderly age range. And the statement that they made based on the study and the follow-up was that statin therapy produces significant reductions in major vascular events irrespective of age, but also that there's less direct evidence of benefit among patients over the age of 75 who do not already have evidence of cardiovascular disease. And the reason why the statement was made was because overall, as a whole group, there was a shown reduction in serious cardiovascular events with statins, but it was very much shifted to a younger population. So a few things with that particular study, and it is the largest study following up people over the course of 5 years over the age of 70. One of the estimations or suppositions they made in the study was that the lower you reduce your cholesterol, the more effective the treatment outcome should be. So you should see a reduction in strokes and heart attacks the more aggressively you reduce cholesterol. Unfortunately, this was also proven false in a different trial, and they reduced cholesterol by 33%, 43%, and 53%, and the risk of a cardiovascular event did not change at all. So it was more about being on treatment and less about actually the reduction in risk in cholesterol, okay? And as I mentioned, in that event group, they put revascularizations, meaning needing surgery to repair heart vessels or clean heart vessels. That was approximately 40% of the number of events. So it, again, highly shifted it towards that group for risk. Also, the mortality for primary and secondary groups, men and women, other comorbid diseases, none of that information was reported separately. So it's hard to determine what groups actually benefited other than age. And they did not report any of those numbers that we had talked about earlier. So it was just benefit by a percentage, okay? So some of the groups that I was talking about, so Towards Optimized Practice, took that data and reviewed it as much as possible and took estimates from a general population to look at how effective statins would be in over 70-year-olds based on current risk. And they basically showed no risk reduction in primary prevention, but they did show a statistical benefit in those people who had had a primary event, such as a heart attack or stroke previously, which we would expect. So the conclusions, and I did put the reference in the slides here, is statins have not yet been proved to increase survival in combined primary and secondary prevention in those over 70, nor reduce serious cardiovascular events in primary prevention. But they do reduce serious cardiovascular events for secondary prevention in those over 70, meaning after you've had a heart attack, but the relative benefit is less than in younger people. So the relative benefit is about 3 to 3.5% in older people, meaning you have to treat about 40, somewhere in there, 35 to 40, versus 4.4% in younger people. And that means you have to treat about 25. So if you've had an event, definitely good evidence. If you have not, it is something to discuss with the doctor about the risks. There are 2 studies that are underway that started just prior to COVID, and they are being studied in over 70-year-olds for primary prevention. And the goal is to get about 20,000 people enrolled in those 2 studies. And unfortunately, due to COVID, they've only had about 800 enrolled so far. So there's a long ways to go, but they do expect that the data to be released specifically for that in about 2025, when they can follow up for 3 to 5 years. So the other thing I will mention with this is if you are currently on a statin, the recommendation is also not to stop without discussion of a healthcare provider. There was historically a small study that did show that there was a temporary increased risk of stroke or heart attack upon discontinuation, if not followed up. So I would advise continued therapy, but if there are questions about whether someone should continue at the age of 75, 85, 95, we can definitely, I can provide you with the information and you can have that discussion with your physician. So the most fun topic and the most pertinent topic for the next few weeks, influenza vaccines. So hopefully everyone here will get their influenza vaccine. I know it's been a lot of pokes for the past few years, but it is definitely shown to be beneficial. And we'll talk about the data here for that one. So which one is right for you? So if people have not been aware, there are a few different influenza vaccines that are currently available on the market. And in Alberta, we have chosen to provide 4 different ones available to the public that are funded by the government. There are 1 or 2 that are privately available, but essentially follow the same format. So we've got Fluzone, which is the most common one that you'll see publicly funded. Fluvaval and Afluria are available, and those are the ones that are defined as standard dose. So they have 15 micrograms of hemagglutinin, which is the protein on the surface structure of the influenza virus for each strain. And I've listed the strains here. If people would like, we can get into that further later. And again, they're a split influenza or split virus vaccine, which means the protein is broken off the surface, broken down, purified out, and then that's what's being provided in the vaccine. Now, in Alberta this year, they've also had an update, and that means anyone over the age of 65 is eligible to get Fluzone high dose, which is the same strains as the standard dose, but with 4 times the amount in the vaccine for each strain. The dose is a little bit higher and a larger volume as well. Okay, so those are the products that are available in Alberta. I'll talk a little bit more about shortages and things like that in a moment. But from statistics, when we look at last year, if anyone has looked at the Alberta Health Services website, there is no data. There were no cases of the flu notified or defined, no hospitalizations, and no deaths attributed to the flu last year. So that's a sort of a statistical anomaly. The prior year, in 2020, there were 1,539 hospitalizations throughout flu season, which basically runs October through April, and 39 deaths directly attributed to the flu. So pretty low in the scheme of things, but a large number of hospitalizations. And a large number of people treated out of hospital due to the fact that there are antivirals that are effective for the flu, okay? And in Alberta, we gave 1.6 million doses, but only 33% of the eligible population. And they did not put that into an age category for who received out of ages. So when it comes to risk, how risky is the flu? US estimates, which are the best estimates we have, indicate approximately 8% of citizens contract influenza on a yearly basis. And that does not include people who contract it multiple times based on risk. Now, last year, again, lower due to hand hygiene, mask wearing, things like that, but the estimate is still approximately 8% per year. And the risk of developing influenza in a seniors living complex is actually quite a bit higher due to the risk of spread. Now, pardon me, the risk of contracting it once you are vaccinated, with the vaccine having a 30 to 40% efficacy, is about 1.9% with the standard vaccine and 1.4% with a high dose vaccine. So it reduces it substantially from 8 to approximately 1.4. So we talked before about the absolute risk reduction. The absolute risk reduction of treatment is about 6%, 6 to 7%. So needing to treat 1 in 10 to 12 people to have an absolute benefit. The difference between the standard vaccine and the high dose vaccine is about 0.5%, meaning you would have to treat an additional 200 people with the high dose vaccine to prevent 1 case of the flu, and about 4,000 to prevent 1 case of hospitalization. Now, the reason why I mentioned those statistics is this year, obviously, if the high dose vaccine is available, they do recommend that for those over 65. There is likely going to be a shortage for it as Alberta Health Services tries to adequately vaccinate those people in community living, long-term care, seniors living facilities. And so those people will have priority first, and then those living independently, where available, it is appropriate to get. Now, if there's a choice or if there is inavailability of the high dose vaccine, the recommendation is the standard dose vaccine. And as I've shown you here, the efficacy is not substantially less, okay? And the discussion this year, again, get the vaccine, because if you have symptoms, they'll assume it's COVID before it is the influenza vaccine or virus. So again, we talked the reduction in risk was about 24% for those, and those at highest risk, it would likely be higher. Now, the other thing I'll mention out of this is the high dose vaccine this year is quadrivalent, meaning has 4 strains. There are no studies comparing that to any other vaccines. All the studies were done with prior molecules, which were the trivalent or 3 different types of virus strain in there. Now, they expect it to be better coverage, but again, no studies currently for that. So my recommendation, get the flu shot, get the high dose flu shot if you're over 65, if at all possible. So now the most fun one, catching more Z's. What medications are the most effective? So for those of you who can view the screen here, I have a cute little picture of a fuzzy little animal in the corner. And so most people think that sloths are the longest sleeping animal per day. And it's actually incorrect. Koalas sleep for 22 hours a day on average. And I think most of us would love to be able to do that. But unfortunately, that's not the case for humans. So very few studies are limited solely to the elderly. Most studies have a small population of elderly that are in them, but very few are able to take that data and extrapolate it out to only elderly patients. They're lumped in with everyone else. So there is a few studies, one in particular, a review of seniors and their sleep-wake cycles. It observed 6,500 seniors, and it indicated that the incidence of insomnia was about 5%. Now that seems, from a medical healthcare provider standard, a little bit low. We do tend to see a little bit more than that in general. And I think that's expectations around sleep as well. But typical insomnia incidence, we'd say probably is about 8 to 10% of people at any point in time, and more so in those over 65. Most commonly, it's described as sleep maintenance, so problems staying asleep continuously throughout the night, and that's about 50 to 70% of those people. Initiation, so problems falling asleep, about 35 to 50%, And then non-restorative sleep, meaning being tired in the morning, is about 20 to 25%. The total sleep average for an older population, so those over 65, was about 6 to 8 hours. And that's a huge variation. 2 hours is a big difference. And they followed sleep patterns and slow wave sleep primarily, which is that restful sleep. And in a person who is 30 to 50 years old, it's about 17% of sleep. And by the time you get to 65 to 70, it only constitutes about 3.5% of your sleep time. So quite a bit less, which is why there tends to be more frequent awakenings as well. So most effective therapy. And you'll notice here how I didn't put any numbers on it because there are no studies that relate those numbers. The most effective therapy was cognitive behavioral therapy. And what that means is problem-solving type discussions, therapies to allow you to better reprogram your body to get a restful sleep. So that includes sleep patterns, going to sleep at the same time each night, or sleep restriction, meaning you don't sleep until you're tired enough to go lay down in bed. And then as you're able to sleep more, you increase that time, as well as not watching TV in bed, changes in behaviors leading up to bed, so eating, drinking, things like that. And cognitive behavioral therapy showed two things: total wake time, which means how much you are awake from the time you first went to sleep till the time you got up in the morning, decreased. So that you were awake for 52 less minutes. And total sleep time increased by 9%. So it increased by half an hour over the course of time to 336 minutes, which if you look at it is still less than 6 hours in the study. And if anyone has any more questions on cognitive behavioral therapy, I can provide some references on what sort of things they did in those programs. So one of the few studies that was done in seniors in a solely older population was done in 2007. So quite an old study and quite a small study group. So it was 340 patients aged 55 to 80. And they were given melatonin 2 milligram delayed release. And the criteria here is it was a delayed release tablet and it was a low dose. So they followed them up, I believe it was about 3 months. I didn't put that in here. But the two improvements they showed were quality sleep and morning alertness. So in the treatment group, 26% of people improved quality sleep and 15% of people who had no treatment improved quality sleep. So what a 10% difference, or a number needed to treat of 1 in 10 people. The relative reduction was about 40%. So it seemed to be about 40% benefit. And the other thing that they found was that there was a reduction in time to fall asleep. So it reduced by 24.3 minutes in the melatonin group and 12.9 minutes in the placebo group. So what that meant was that there was about a 12-minute difference in time to fall asleep. So relative difference for those people having a difficult time falling asleep, but not as significant as many people would find. The qualifier to this study is they only did the study for about 3 months, and there are no great long-term studies on melatonin because it is a pituitary hormone, so they don't want to follow for long periods of time. So now the risks of medication treatment, and this is a big thing. So on this slide, as you can see, sloths get about 20 hours of sleep. So koalas beat them out still for sure. So one thing with sleep medication or insomnia is there are some health conditions associated with poor sleep. So this isn't just a discussion about is one thing beneficial and will it help? There's other risks associated with it, and it has to be a mesh of the two. So a few things that have been found is 23% of people with severe insomnia, and typically defined as less than 5 hours of sleep, do have an increase in diagnosis of depression or depressive symptoms if they have had that experience in the past. People are 2.5 times more likely to have diabetes if they report less than 5 hours of sleep. Now, unfortunately, there's no baseline here of number of percentage of people. Diabetes diagnosis ends up being about 30% of people over 65, but new diagnosis is about 3 to 5% of people. And there is an increased risk of heart disease of about 1.5 to 4%, or 1.5 to 4 times, sorry, for people who sleep less than 5 hours. So cardiovascular disease, diabetes, and depression are all related. Now, the risks of treatment, unfortunately, are just as high. So all current prescription therapies that are used for insomnia are listed on what's called the Beers criteria list, meaning for older patients, so over the age of 70, as well as for high-risk patients or patients with other medications, the risk has been shown to outweigh the benefit, and those risks include falls, daytime dizziness or drowsiness, confusion, delirium, dementia, and other factors like that. So it is a risk versus benefit, and monitoring is more appropriate. So for most people, if they've taken anything for sleep, they've heard of Z drugs, so Zopiclone, Zolpidem. In the States, there's Esopiclone, which is Lunesta. And those drugs are very effective. So the studies have shown that about 1 in 4 people benefits in hypnosis, so getting to sleep, and about 1 in 8 people benefit for duration of sleep. But there is also a 5 times risk of cognitive related adverse events. So confusion, dizziness, daytime drowsiness. And that 5 times risk is referred to a baseline risk of about 10%. And 2.5 times the risk of falls. So when you look at a fall risk over the course of time, we've shown the statistics here, approximately 1 in 3 women over time will fracture or sustain a hip fracture in their lifetime. And it actually increases that by about 50%. And men will sustain it about 1 in 12. So, and again, the statistic here for hip fractures, it's reported about 86% occur in those over 65 years old. So it is definitely something to discuss with a physician about appropriate use. There is benefit to using lower doses possibly, and also for shorter periods of time to manage insomnia. So the last thing to mention here is we talked about number needed to harm outweighing number needed to treat. So in this particular case, the number needed to treat is about 1 in 13 people overall for insomnia. The number needed to harm is 1 in 6. So twice the number of people will observe harm than benefit from these particular class of drugs. And then the last thing we'll cover really quickly is diabetes treatment in older individuals. So again, the statistics here, current population data talks about the occurrence of diabetes about 22 to 33% in adults over the age of 65. And this is BC and US data combined. So that's the best evidence that they're collecting right now. Now, this has also changed a little bit because the diagnosis of diabetes has changed. So when it becomes a little more restrictive, meaning an A1C lower or a blood sugar requiring to be lower for diabetic patients, then you'll see more people being diagnosed and observing treatment. But as of 2019, only 7 studies were conducted solely on older patients with diabetes or pre-diabetes, which meant an A1C of 6 to 6.5. And only 2 of them were randomized and controlled trials. So very few, not great evidence. And so the outcomes from all of those trials were pretty common sense. Modest exercise program reduced the onset of diabetes and effectiveness of treatment. And that was defined as 30 minutes of walking 5 times a week. And it also decreased the risk in high-risk individuals. So again, those pre-diabetic patients. The lowest hazard ratio, so the lowest risk of harm for a patient over the age of 70 was an A1C of 7.5%. So not quite as aggressive treatment as the targets for younger people. And it was done, the average was done in over 65, but again, varies, best estimates were over 70. And the A1C averaged 6 to 9%. And the lowest hazard ratio for a fasting glucose, so first thing in the morning glucose, was actually 7.8 to 8.3. So much higher than the current targets for diabetic patients in general, which is 5 to 7. Discuss blood pressure targets, a target of less than 130, which is by the American societies, and less than 140, so again, less aggressive treatment in the national journals. And the last thing that it showed was early onset diagnosis or intensive therapy had, if you were over 75, had poorer outcomes, so more risk of hospitalizations. So pretty common sense. don't have to treat as aggressively in older group of people. And based on that, Alberta did change some of their guidelines for coverage, which is for most people beneficial, for some people not so beneficial. So I've shown here what the new guidelines are in Alberta for what they cover for treatment. And so this is for diabetic testing supplies. If a person is on insulin, they've actually increased the maximum coverage because they do expect more aggressive testing due to the risk of low blood sugars and the variance in blood sugars that's going to occur. So they've increased the coverage to approximately 3,000 strips a year, or 8 tests a day on average. For those treated with oral medications with high risk of hypoglycemia, and there are a few still being used, they cover 400 test strips, or approximately $320. And those treated for diabetes with low risk of hypoglycemia, which includes some of the newer injectable products and some of the newer products out on the market, it's $160. So approximately 4 tests a week, which is reasonable. The one thing that they've now included is if you are pre-diabetic or right at that 6.5 A1C, they now allow coverage for testing for those people treated via diet and exercise and do not require medication therapy. So that's a benefit to those groups in that high risk category, but not yet requiring other treatment. So that's a positive thing. And the question becomes out of this is when to test, because either you're limited with testing supplies, or how aggressive do you want to be in monitoring? And there's lots of discussion about that. Random testing is not very beneficial. So just at one point in time, it is about obtaining patterns. So if people do have questions about when the best time to test is, there's something called pre and post meal testing. So you test before a meal and you test 1 to 2 hours after to get the best evidence of how food is affecting you. And again, if people have questions, we can discuss that further. So that's the 5 slides that I've gotten to, or the 5 different categories we've gotten to. And I have 2 minutes left, so I'm just going to quickly run through home blood pressure monitoring, just for fun. So when people talk about home blood pressure monitoring, when they define accuracy, most home blood pressure monitors are within 10 to 15% of what a perfect reading would be. And that's an acceptable variance. So the goal is to get multiple readings to get the best idea. Home blood pressure monitoring has been shown to be more effective at diagnosing hypertension than at a physician's office, partially because you get better readings at different times, and also because you're able to take more readings and it's a better indication of what your average blood pressure over time is. So there's some statistics here about differences, and there are blood pressure monitors that are accurate and inaccurate. They were studied by Health Canada, and there is a site you can go to reference which blood pressure monitors meet gold and silver standards for accuracy. The one benefit of physician monitoring is it does pick up treatment goals better. So if you start on a medication therapy, physician office detection is more effective. So if people are testing blood pressure at home, to conclude, it is more accurate for detecting high blood pressure. It is more accurate for monitoring long-term therapy. And more people who monitor blood pressure at home will meet treatment goals by 6 months. So it's about 60% of people, if they're aggressively monitoring at home, will meet the treatment goals. And so the guidelines for monitoring are 2 consecutive treatments, or 2 consecutive monitoring at the same time, about 2 to 3 minutes apart. You do that morning and evening for a minimum of 4 days, but ideally for 1 week. So then you average those all out, and that is your average blood pressure. And then if you take that to your physician, that's the best information. So I think we'll stop there. I do have a few slides that I've attached from prior presentations at the end, and people will have access to those as well. So I will qualify everything I've said as no information presented today is an attempt to convince you for treatment or against treatment, only to provide you with information on the benefits and harms, and our goal is to support your decisions. Does anyone have any questions?
This is fantastic, Chris. I know that we've kind of run a little bit out of time, but would you have time for maybe one question?
Sure.
Okay, great. And thank you so much also for putting your information there as well. And then we also have on Chris's event page on our www.seniorsforum.ca website, a direct link as well to Health Canada for more information, or My Health Alberta, sorry. But yeah, if anybody has, I think we have time for one question. So if you would like to ask Chris a question, you can do it two ways. One would be to type a question in the Q&A chat box. And we have one right there.
Oh, on the slide for diabetes, what is 20514? That's a good question. Let's see if we can. Oh. That's a very good question, and I wish I knew the answer. It might just be a glitch in my presentation from adjusting it.
Awesome. Thank you, Chris, so much for your time.
Not a problem.
Was absolutely exceptionally informative. This was absolutely phenomenal. If anybody would like to follow up with for more information as well, feel free to reach out directly to Sage, and we can put you in touch with numbers as well.